cerebrospinal fluid biomarkers that you need to take lumbar puncture, spinal tap, are now classical biomarkers. So they are on the market and in the clinic since many years, over 20 years in the most countries, and they are used especially in memory clinic setting. As I work in Sweden and I work with Swedish Dementia Registry, 90% of the patients from memory clinics in Sweden, they had these biomarkers done. However, it's not the same for other countries, and it's not the same even for patients from primary care setting.
Here in the United States, many patients and their care partners are very resistant to the idea of lumbar puncture. They see it as something not only very painful, but also really dangerous. And putting that in the context of somebody who has some memory lapses, may have mild cognitive impairment, they're not willing to, in any way step forward to take that step to get a CSF analysis because their perception, despite my counseling, is that the risk is much higher than the benefit. Unfortunately.
Can I just add that other challenges that are on the systems level? So I'm in the state of Georgia. It's a very big state geographically and population-wise. I think there are 3 centers where someone could get a lumbar puncture if they were interested. So I think the barriers exist on certainly the layperson and the patient side in terms of their understanding their calculation of risks and benefits, but there are also quite a few system barriers, certainly in the US for health systems that offer it and practitioners that are trained and qualified to do the procedure.
Yes. Also in Japan, the CSF test is good because less cheaper test compared to the amyloid PET scan to check the age status. However, it's really bit invasive for patients, and also it takes more time for physicians. So it's really difficult to perform CSF in clinical practice. And also in Japan, some patients and family mistakenly think lumbar puncture is as a bone marrow test because in Japanese, a bone marrow test and lumbar puncture also have a similar same Chinese character, so a little bit confusing. So I would say it's very essential for us to have a detailed explanation, performing a detailed explanation and communication with patients and their families.
It's our own perception sometimes, kind of the barriers in our own heads. It's how we communicate a lumbar puncture to the patient, because if I'm confident that I can do it, I think it's not a very risky, not a very painful procedure. It's an outpatient procedure, and that's how I communicate it to the patient. It's actually quite rare that a patient will say no. So it's really about educating and training the clinicians, I think, is very important.
As with other biomarkers, such as fluid biomarkers, it's important to recognize that imaging biomarkers also have inherent limitation in sensitivity and specificity. Even in tests with relatively high sensitivity and specificity, such as amyloid PET, the positive predictive value may be low if performed on a population with a low pretest probability of the diseases. Even in patients being considered for treatment with elevated targeting drugs, it's crucial to first establish a suspicion of Alzheimer's disease as an underlying pathology. This should be based on a comprehensive clinical evaluation, including a detailed medical history, neurological examination, and neuropsychological testing, followed by blood tests and MRI to rule out treatable dementia before proceeding to amyloid PET. While amyloid beta strongly supports the presence of a certain threshold of amyloid beta accumulation, such findings may reflect incidental mixed pathologies, particularly in elderly patients. Thus, diagnosis should be approached from a multidisciplinary perspective.
I agree. It definitely takes a multidisciplinary approach. And I think that some of the core messages that I always take away when I think about imaging are the fact that we really need to be efficient. We're going to be identifying most of the patients with cognitive impairment. Y'all are incredible specialists, but patients aren't going to be coming to you first. We're going to be seeing that in our clinics. And I think it's really important that we do the assessment clinically. We look at other factors that could be affecting cognition, such as medications, lifestyle, et cetera. And then we start up with some laboratory tests and, very importantly, a brain MRI when at all possible. And that just makes things so much more efficient.
When it comes to clinical utility and clinical and interpretation of results in the clinic, I think the disease stage makes a huge difference. So and in terms of patient counseling, if someone has full-blown dementia, and then a positive amyloid PET scan, the situation may be very clear. Of course, this is still an important piece of information when it comes to selecting individuals who are eligible for treatment with a disease-modifying drug. But as we move into earlier and earlier stages, I think it becomes more tricky. We want to identify pathology in pre-symptomatic individuals, and that's where the relevance of a positive amyloid PET scan becomes a little bit kind of unclear, and patients want to know, how long do I have? How long will it take me to progress to dementia? I barely have any symptoms. I have a positive PET scan. So these are challenging conversations that we have to get used to in the near future, I think.
I would also add in the space without a national health service and payer, this is the most expensive test option that I have. And that's also that major side effect, if you will, to someone's savings account. It is covered in very, specific situations. And I think that, of course, gets into then very thoughtful and appropriate use, both clinically and based on sort of guidelines and how payers will see it. That said, is also gold standard. I think more people are starting to think about it in that way.
Blood-based biomarkers are the real hope for us in primary care because we lack time. We don't see many patients, patient after patient, with cognitive impairment. We know our diagnostic accuracy isn't as secure. Blood-based biomarkers in terms of a context that we as clinicians understand, speaking to your point, Robert, something we're comfortable with, something our patients are very comfortable with, that could be a real game changer. And we do see some research that suggests that accuracy is improved using biomarkers beyond what we'd expect from either a PCP or a specialist diagnostic assessment. Now, that is questionable. If you do a full psychological assessment, then I think your diagnostic accuracy is going to be pretty darn good, especially when you combine it with, as we discussed, an amyloid PET study or a CSF analysis. That's really, I think, the gold standard. But blood biomarkers could certainly move us closer to that. And if nothing else, identify more patients. There's still, though, how to weigh them and make them the most accurate possible, and also just physically how the test is done. We need stronger immunoassays that can make them more broadly available, where we can do thousands of tests at a time across the country. So that's really something to look forward to. And we're right there. I'm not sure we've really crossed that threshold yet.
They work quite nicely in controlled clinical trial situations, but I think they still require a little bit more real-world evidence to kind of move them into a near future where they will hopefully replace the more invasive and expensive procedures.
I think that it's important with blood-based biomarkers also know both positive predictive value and negative predictive value. Recently in Sweden, it was from community-based patient in Nature Medicine paper at this biomarkers. It was phospho-tau 217 and phospho-tau 181. they have only negative predictive value. Still information that patient can be a little bit more sure they are healthy, will not develop Alzheimer's disease with some probability. Because as for now, all this blood-based biomarker, they are not in clinical use, so we need to have more research on them.
Yes, I totally agree with our discussions, and I would say this is not an issue with blood biomarker themselves, but rather than issues with the degree of understanding of the doctors who use the biomarkers. Because blood biomarkers are more convenient compared to the PET or CSF tests, so they may be performed on populations with lower prior probabilities, resulting in the decreasing the accuracy of blood tests. It's very important for us to understand the role and the limitation of biomarkers in the communication, community-based populations, I think.
I think the most important points here are that the patients that we see in clinical practice are quite different from the patients that we include in clinical trials. So they have much more frequently mixed pathologies, and those mixed pathologies impact on the interpretation of the biomarker results. Someone with amyloid pathology may have Alzheimer's disease, but the Alzheimer's disease pathology may not be the most important driver of the clinical and cognitive impairment, but it may be their vascular co-pathology. So that's quite important in terms of selecting appropriate patients for disease-modifying therapies. In clinical practice, it's not that rare that we see atypical presentations of Alzheimer's disease, which may mimic other neurodegenerative disorders. I guess one of the issues in Europe, including in Germany, is that none of the new disease-modifying drugs are approved, and primary care physicians are not very motivated to diagnose dementia because they don't think that any of the information is actionable. There's nothing they can offer in most instances. And hopefully this will change when drugs are available.
Alzheimer is a rather complex disorder, so it will be very difficult to treat with one substance, one way of treat. A lot of different ways to think how we approach Alzheimer's disease with all co-pathologies. We know it's Alzheimer, we talk one. We know it's a lot of subtypes as well. So I think a lot to come as well. So we are in the interesting time that we will have more information both about biomarkers and also other way how we can approach for the treatment options.
For the last 3 patients, I've done blood-based biomarker testing. It's not been around making a decision. We already knew that they were not eligible or appropriate for anti-amyloid therapies, but it was really about being able to have some sense of, I'll say certainty, but let's say more confidence in the diagnosis as they were making really milestone decisions about treatment and care planning. And it's been very meaningful to them in the case where the patients were able to participate meaningfully in the discussion, very meaningful to their families to understand what their plans and preferences were in light of that additional information. The complexity around dementia care is that the communication is often with the patient in front of you and often with an informant, a supportive person. We would not necessarily call them a caregiver at that stage, but that is, and those are your quality measures. So that's different for many clinicians who are very much maybe used to a one-on-one. I know that differs in setting and by culture, but it's helpful to understand that the entire process from that initial suspicion or concern or reporting of symptoms throughout the disease course is really enclosed in one large dialogue. We have new guidelines published the end of 2024 on the detection and evaluation of symptoms most likely due to Alzheimer's disease. And that visual sort of envelops the entire process in this ring of a shared communication and a dialogue in order to make decisions about what types of diagnostic evaluation we would like to pursue, the trade-offs and the risks and benefits of each of the tests, including biomarkers that we've discussed today, what we can reasonably expect from those different levels of evaluation, what we can reasonably expect from different pathways of treatment and supportive care, what their goals are overall for the process. Do they want that very specific gold standard diagnosis, or would they like to understand broadly that there is this syndrome that will progress? And so, and then also, who will we communicate with going forward? So these are things we try to set the stage, ideally, early on, so that that even that in and of itself is a shared decision from the beginning of the process.
And of course, with individuals who are cognitively impaired, it becomes more difficult. That's why you have to involve the family, the caregivers, proxies, informants. So it's more kind of a systems approach that's required compared to other situations in medicine.
This is beautifully stated. I can just say that, even in the setting of an ultimately fatal disease, patients who go on that trip of a lifetime that they've always wanted to take, or they talk to a loved one whom they've been estranged with for 25 years, and yet they have those what matters most moments. They get to see the birth of a great-grandchild. All those things are some of the best parts of my practice, and hopefully a lot of clinicians sharing this program will feel the same.
With the recent clinical implementation of A-beta targeting therapies, novel treatment for Alzheimer's disease, diagnosing dementia now requires identifying the underlying pathology. To accurately determine the pathology of dementia, it's essential to understand both the significance and the limitation of biomarkers. I'm confident that this program will be highly valuable for all professionals involved in dementia clinical practice.
This educational program is very important for all the healthcare professionals involved in dementia diagnosis and care, including neurologists, psychiatrists, and geriatricians, because we all need to learn how the new biomarkers should be used in clinical practice outside of trials and controlled studies.